Hey, everybody who is just starting to shuffle in. We will be getting started with today's discussion in just a few moments. I'm just going to give folks a few more seconds, about a minute, to settle in as I see people are actively joining us right now. So bear with us just a few more moments, and then we'll go ahead and get started. All right, I'm going to go ahead and just do some housekeeping for us quickly. Knowing that folks are continuing to shuffle in, but I want to thank everyone for joining us today for our webinar, It Takes a Village, Leveraging Collaborative Partnerships to Increase Access to Behavioral Health Services. Today's session is entirely live and it's made possible through our support by Headway, who we'll be learning more about shortly. We'll also be sharing a link to today's recording of today's visit, our meeting after the session today. So in case any of your colleagues haven't been able to make it, or if you have to hop off early, not to worry, we'll be sharing that out along with the slides shared by the presenters today. Just briefly, my name is Andrew Philip. I am the clinical lead and senior director for partnerships here at the Primary Care Development Corporation. PCDC is a national nonprofit based here in New York, really wholly formed and with the mission of enhancing health equity through catalyzing excellence in primary care. We do this through capital investment as a community development financial institution and have invested over $1.3 billion to enhance primary care access since 1993, through training and technical assistance on a variety of topics related to primary care and behavioral health, and also through advocacy and research to ensure adequate support for safety net providers, in particular in communities where it's needed most. Today, our guests, Dr. Anitha Iyer of Mount Sinai Health System and Scott Munro of Headway. Dr. Iyer is the Director of Behavioral Health and Population Management at Mount Sinai Health Partners. In this role, she aims to promote better clinical outcomes for patients, streamline evaluation and treatment processes, and optimize provider performance through a systematic and data-driven approach. Scott Munro is the Headway head of physician partnerships, where he supports primary care groups and health systems by giving them a seamless path to manage their patients with one of Headway's 8,500 plus affordable in-network quality mental health providers. So we'll hear more about both of these. But before I do, I want to launch a poll and just find out who folks are who are here. Who are you? I'd like to know what your role is. So you're going to see a poll pop up in just a moment. Let us know which of these most closely maps onto the work that you do. And if you don't fit into one of these categories, if you're not a clinician or you're not in policy or management, if you're an other, I'd love to know what other position you might be and what kind of work you do. You have access to the chat at the bottom of your screen there, and feel free to just chat in. Let us know who you are, where you're tuning in from, and what you do. And it'll really help us in shaping the discussion today. So we'll give just another second or so for folks to, looks like we're getting most of our selections here. And let's go ahead and bring up the responses. Great. Okay, so really interesting group here. So we've got a few people who are in primary care, a decent amount of behavioral health folks at 16%, and a majority of administration and management, which makes sense, right? We're going to be talking today about really system level and clinic level interventions that you can take to enhance behavioral health access. Also really happy to see folks on the government and policy side here, and some students as well. So welcome to our diverse audience. This is just great to see. So thanks for completing that poll there. And again, feel free to use the chat. I see we're getting some folks chatting here. Oh, cool. Excellent. Disability Task Force. There's been a lot of real need, frankly, and innovation we're seeing in the integrated care and disability space as well. As we're talking about accessibility, that really means all form of access. So just as a quick preamble to our discussion, we will be talking about behavioral health access and strategic steps that we can take to make sure that when referrals are made to behavioral health, that they're not simply lost to the ether. But to that point, I have two more poll questions before I turn it over to our presenters. And I'd like to get a little bit more information about your experiences. Maddie or Kimmy, we're going to bring up our next poll. And I'm curious, for those of you who either are in roles where you handle patient referrals, or if someone in your system or broader organization engages in referrals, how do you tend to do this? If a patient, let's say you're in primary care, if the patient needs a behavioral health referral or vice versa, do you give them sort of a sheet with different resources on it? Will you sit with the patient and call and arrange for that referral appointment? Do you have some sort of internal system where you're able to place a consult directly? Maybe you're part of a broader health system, or you have a formal partnership, or do you have someone on the team who is kind of the designated person? We have a care manager or a case coordinator who we refer these patients to, or do you use a formal platform or a service? Curious. And it looks like we're getting a pretty interesting spread here, a lot of diversity. So just give people a few more seconds to sort of wade through the options. And again, here, if you don't fit into one of these neat categories, let us know what this other thing may be. Also, I'm seeing other people popping in. We've got prevention coordinator, educator, welcome, behavioral health case manager, care coordinator. Great, good to see you. I'm from our friends in New Hampshire. Definitely let us know what care coordination looks like from behavioral health referrals. So we can pull up the results now. And what you'll see is a pretty even distribution here in terms of either making that referral directly with patients in the room or placing that consult perhaps after the fact. And now I have one last poll, and this really relates to your experience around referrals. And I'm curious, how does it tend to go? Do you have a system in place that's just reliable? It seems to work really well. Most of the time, your referrals result in an actual visit on the other side. Perhaps you even get information back on the other side of that referral about how it went or any next steps with the patient. Do you have some sort of system in place that works some of the time? Is there really no system in place, but through whatever method you tend to get patients where they need to be? Or is it just like a shot in the dark and we hope for the best? Or something else? And again, feel free to use the chat. So we'll give you just a few more seconds on our poll items here. All right, so I think we can go ahead and pull our results here. And I know this is a complicated one. You may not know the answer to, which is something interesting to think through in today's discussion, but it looks like a slim majority of folks do have a good system in place that seems to work. But I would say actually, when we combine them together, most people either have something in place that works some of the time or really doesn't have anything formal in place. And so I think that's a good launching off point here for our discussion. And this is really, I think, the pain point now, really, especially the past 2 years, as we've seen just a skyrocket in terms of the need and demand and attention given to behavioral health. We're also seeing these pain points around actually connecting patients with services. Whether you're in a rural area or in an urban area, actually having a patient, identifying a behavioral health need with a patient, and then seeing them through to accessing those resources, whether it's in your own organization or externally, tends to be a huge risk, right? That's where we tend to see great drop off. A very small percentage of patients on average actually make it to their first mental health appointment. And so part of when we're talking about integrating services is thinking about how do we address that? How do we get people from point A to point B, wherever that may be? So Anitha, I'm gonna, with that said, I'm gonna turn it over to you to get started. And again, thank you so much for joining us, and excited to hear about your work with Mount Sinai.
Thank you so much for having me. Really appreciate the opportunity to speak here today about the work we're doing at Mount Sinai Health Partners and Mount Sinai Health System to try to come up with sustainable and scalable strategies for behavioral health integration. Right? It's not just about getting behavioral health integration in place, but it's about making it so that the diversity of practices that we have in the system are able to adapt and utilize it in a meaningful way. So before I go to the next slide and talk to you a bit about sort of our high-level strategic plan around behavioral health integration, I want to just sort of provide some context into the way this work unfolded over the last year and a half or so. My first day at Mount Sinai was March 17th of 2020, which was just around the time that New York City was contemplating whether or not to go into lockdown. And then we subsequently did, within the next several days, sort of go into at least a partial lockdown, if you will. It was a really eye-opening environment to walk into to do this work, right? Because I got to see firsthand how passionate our providers are in supporting patients and how willing they are, and especially in primary care, to roll up their sleeves and do what needs to be done. Sometimes at cost to themselves and risk to their own lives in terms of, supporting patients with COVID and such. But it was also simultaneously at a time when the mental health need was really, developing into a crisis of sorts, right? I mean, our country has not necessarily been in non-crisis mode with mental health, for since before COVID. But it really, I think, became very stark when you look at a threefold increase in depression and anxiety rates. And it was our primary care providers, in addition to behavioral health providers, that were really front line to seeing this unfold and noting that sort of the resources are really dire, or the systems to connect patients are just not enough or not adequate. It also allowed me at that time to see how diverse the provider community is, primary care provider community is, and how much variation there is between providers in terms of their ability to be able to provide supports in-house and whatnot. And I think that context was really instrumental in the strategic plan that we then subsequently laid out, which, if you go to the next slide, I can sort of quickly highlight some of the high-level aims. Before I go into the details on this slide, I just want to clarify that Mount Sinai Health Partners is the population health wing of Mount Sinai Health System. And it's also the IPA. So the network, the clinically integrated network of primary care providers, as well as specialists, all together who, engage with Mount Sinai Health Partners in value-based contracting. So Mount Sinai Health Partners manages that relationship with payers, but also provides a variety of clinical supports for care standardization, for clinical integration, learning communities, and so on, to really build a population health emphasis within the health systems. And all told, our clinically integrated network supports about 450,000 attributed lives through the clinically integrated network. So it's large, and it's spread out throughout the New York metropolitan area. So our key sort of tenets that we borrowed from the Mount Sinai Health Partners and the population health philosophy that guides our work into the development of our behavioral health strategy are listed here on this slide. So I'll quickly walk through those. So really emphasizing a population health approach, meaning emphasis on patient outcomes, making sure our patients are getting better, and that we can provide quality care that is measurable, that is observable, but also that we are reducing the total cost of care. As we know, behavioral health expenses account for a significant amount of healthcare expenditure in the United States. And when you look within that, in particular, it is striking that it is the spend on medical services for patients with behavioral health conditions that drives a large portion of that expense. And so if we can find reasonable ways to support behavioral health needs when and where they present within a healthcare system, which frequently is in primary care, right? 80% of antidepressant prescriptions in the United States are written by primary care physicians. So if we can support behavioral health needs there, our hypothesis is that we can then drive down those costs that are often presented by avoidable emergency room visits or avoidable hospitalizations, not just for behavioral health needs, but also for associated medical needs, including for chronic medical conditions like diabetes and hypertension and so on. So that's sort of our aim, right? Reducing total cost of care, promoting shared savings through our value-based contracts, but doing it while driving quality patient outcomes. We also emphasize stakeholder engagement, really understanding this diverse group of stakeholders that I just mentioned, both primary care physicians and their practice aligned staff, but also behavioral health providers, right? Not assuming that there is a one-size-fit-all approach that is applicable in a system as diverse as ours, which I think is probably similar in large healthcare systems around the country. And then building and nurturing partnerships internally, but also with external stakeholders. Because as the title of this webinar suggests, like it really does take a village. It takes people from all walks of life to be able to support and solve this problem. The other piece that we are emphasizing in our behavioral health strategy, kind of borrowed from our department overall, is a data-driven approach. So we're looking always at key trends from claims and EMR data to identify areas of need. So for example, we look at, how many patients in a 1-year timeframe had at least one F code, a behavioral health code, in at least one claim by practice, and what proportion of the practice does that patient population account for, right? To give that information back to practices is quite powerful, to be able to tell them 25% of your patient population has a behavioral health need. That then has incredible, meaningful conversations that it can then start in terms of how are you supporting them, how can we help you support them, and so on. We've also been looking at, time to follow up as evidenced in claims. So how long does it take between a behavioral health diagnosis showing up on claim 1 and claim 2 within the same year, as a proxy for how frequently is the patient talking to their primary care provider about their behavioral health need. We're also building a framework for assessing impact of our work, including what you'll hear about today, on some of the more sort of meaty population health metrics, like avoidable ED visits. Are we seeing a reduction in that? Are we seeing a reduction in associated costs, and so on and so forth? Prescription fills, that's a really big one. Polypharmacy, there's so many key population health metrics that drive costs that we have found and emphasized kind of building from the ground level in our strategy as we move forward. And then leveraging technology, right? Looking at the key gaps that technology can reasonably fill. Technology is not a panacea, it doesn't solve everything, but when situated within a meaningful strategy, it can be powerful. And so some of the things we're looking at are things like closed loop referrals, e-consulting platforms, a virtual learning collaborative, which I'll tell you about in the next slide, and so on. If you could go to the next slide, Andrew. So this is probably a hard to see slide, but I'll quickly just note, these are some of the initiatives that we are either in the process of launching or have already launched, consistent with the behavioral health strategy that I just noted. The one with the pink circle around it, our approach to increasing access to behavioral health care, which we launched in June of this year with 5 pilot sites in partnership with community-based organizations, including Headway, is the one that we'll talk a bit more about today. But we have, as I mentioned, sort of done a few other things. So we launched a learning collaborative based on the Project ECHO model. We called it Mind Matters ECHO. We just completed the first module, have really good results thus far. Looking, and it's really a space for primary care providers to present cases and get live consultation from specialists. We are in the process of launching a pre-visit screening strategy that is digitally sort of delivered, and we are working toward building a behavioral health integration pilot that we're going to test in some key sites. Notably, I just want to say that, we have found that, again, engaging stakeholders and figuring out that these are, in fact, the right strategies across practices, but also in understanding the sequence within which to launch them has been a key lesson that I just want to note. So you see that kind of visually represented here. We want to solve for the referral access issue first before we start encouraging practices to engage in widespread screening of their patients, which we want. We want universal screening, but practices can be quite hesitant in screening patients if they don't know what to then do with them after, where to then refer them. So that's why we're sort of sequencing our approach in the way that it's laid out here. I won't spend too much time on this so that we can have more time to talk about the specific project to increase access to behavioral health. But if there are questions about any of our other projects, I'm happy to answer after. Next slide. So, when we decided where do we start, when we were looking at where do we start, right? Again, we looked at the data. It was clear, and you'll see in some of my subsequent slides that, we have several practices across our large network where there is high demand for behavioral health services. We saw, high proportions of behavioral health patients within their practices. But where do we start? What is sort of the point at which, our intervention is most needed? And it was clear from talking to stakeholders that solving for access to behavioral health referrals is key. That was the biggest pain point. So it clearly became the place where we wanted to start. So one of the things we kind of did was convene a work group of primary care providers from our network and presented different strategies for testing out access to behavioral health and started to get their input on what would work, what would be adaptable within their practices, what would not, what would work within, sort of the time they allot for conversations with their patients, what is their current workflow, and kind of how can we operationalize a solution that is not disruptive to their current workflow. And in this process, we tossed out some strategies that we had put in front of them. It was either too fancy or sometimes it was basic things like, this sounds really amazing to have a video visit with a behavioral health clinician in the room, but I don't have the space to put the patient because I have another patient waiting. Or how do I bill for that was a common question. So we quickly learned that the strategy we put in place has to be one that they can reasonably use and meaningfully adopt. So the one we used is kind of starting from the point where the PCP refers the patient. We adapted the strategy so that the PCP just uses the existing workflow that they already have in place for making a referral. If they have embedded social workers that their practice is already invested in, they refer to them. If they don't, then as a benefit of being part of the clinically integrated network, they have access to centralized care management services, which are social workers. So we said, okay, well, you can put in a central consult through Epic, which is our EMR, and reach a social worker, and then they will pick it up and take it from there. Once the referral is made, either to their embedded social worker or to our centralized care managers, they then call the patient. They make sure the patient understands that a referral was made. They make sure the patient wants a referral. This piece of advice came in from talking with our behavioral health clinicians within our system who frequently reported that patients would arrive for an intake appointment and not know why they are there. Or they would say, I'm here, but I think that's because my doctor wants to be here and I don't want to make them upset by not showing up, right? So we wanted to avoid that and insert this kind of point of contact through the social worker where the patient understands that a referral was made, they intend to follow through, they can verify that their insurance is current so that the social worker is looking for places that will actually be able to accept the patient eventually. And in this particular day and age, given how many behavioral health services are really being offered through telehealth, this also gives the opportunity to check in and make sure the patient is amenable to telehealth. Or if they only want in-person services, then the social worker can specifically look for places that are offering in-person services. Then our social workers take that information from the patient and then they check for options internally within our health system. They can try multiple sites within our health system. It's a large health system. We have several Article 31 clinics and specialty outpatient programs and such. And then they document the outcome. If there is not an appointment available within our health system, which in this world of sort of high mental health demand, sometimes that can be the case, then our social workers will reach out to our external partners, including Headway. For commercial insurance, they reach out to Headway. For Medicaid or Medicare, we have relationships established with 2 CBO partners. So we have launched this at 5 sites. We trained all the care managers and social workers that are aligned, making sure everyone is familiar with sort of all of the behavioral health basics, but also strategies around risk assessment, safety planning. If that comes up in the conversation with the patient is more acute than was indicated on the referral, they know how to sort of manage that. And then they can determine the right level of care and proceed down this path. We soft launched in mid-June. Our referral volume didn't really pick up until July 1st, I would say. And then we kind of maintain, it's ongoing at this point in time, and the preliminary results are quite promising, and we plan to scale. I will note that, we have put in place recurring update meetings with all the stakeholders involved in this, right? So care managers, primary care physicians, our partners, including Headway, so that we can collaborate in figuring out whether we are solving the problem that we started out to solve as we scale. Next slide. So just a bit about the pilot practices, so you have a sense of kind of where we are testing this. We started with some of our larger practices. So as you can see, some of these practices are multi-physician, quite large patient panels. And you can see the kind of, if I can draw your attention to the last column, this is based on that strategy I mentioned where we look at claims to see how many F codes within a year. And you can see that, almost 25 to 30, upwards of 30% of the patients in these practices have at least one F-code diagnosis, one behavioral health diagnosis in a 1-year period, right? So those numbers, just for context, are large. New York City and New York State report a prevalence rate of 20% of mental health, of people with at least one mental health condition. So these are large groups of people with behavioral health need in these practices. And so all of these practices sort of welcomed this pathway and have been partnering very kind of meaningfully in the process with us moving forward. And then you just see sort of they're geographically spread out. So for those who are familiar with New York City geography, this is basically the boroughs of Manhattan and Queens and different parts of the borough. But as I mentioned, our practices, our network extends across the greater New York metropolitan area. So as we scale, our geographic reach should improve. Next slide. So some preliminary data, and I know Scott will talk a little bit about findings from Headway's side as well. The volume has been pretty impressive. It hasn't been nothing. When we started it, of course, you worry, what if no one refers anybody? But we've had the opposite of that to some extent, right? We've had about 156 referrals through mid-October, from July 1 through mid-October. And, I want to just highlight, the incredible success we have had with Headway. And the workings of how Headway does the work that they do, I'll let Scott speak to, but, this is really promising, right, to us as we endeavor into this, that's a lot of people that are connected to care. We have similarly promising results with our CBO partners that are providing Medicaid and Medicare billable services. And so this has been an incredibly encouraging experience thus far. Next slide. So before I turn it over to Scott, I just want to highlight sort of some key takeaways again from a strategic planning standpoint for any other folks on the call that are considering replicating something like this, or you're thinking about something like this in your own systems. I think the pieces that we have found to be key are making sure that you are picking the right pilot sites, in terms of size, volume of behavioral health patients, payer mix, particularly if you're engaged in value-based contracting, right? It pays to make sure that your payer mix aligns with the contracts where you're trying to drive shared savings. I know financial outcomes are not what we always want to talk about, but they are important because ultimately they do equip systems to reinvest in important care. And then we've also found it really helpful to focus on practices that have a desire to participate in population health management. I've already mentioned, but I'll just reiterate, ensure that the pilot pathway that you're trying to implement will actually work for your PCPs, will work for patients. And as we did, it's okay, right, to have people tell you this will absolutely not work in my practice, and then be willing to learn and adapt, because that then leads to cumulative success. Care coordination, I can't emphasize this enough. The literature, and you probably see that on the slide, has cited that the point at which referrals are made is the point at which the patient is actually most vulnerable in terms of an access and connection standpoint, because it puts the patient, particularly if you leave them with a number of referrals, that they can then call through. And I was really glad to see that from the poll, it doesn't look like anybody on the call is doing that, which is, giving the patient a list of numbers to call. But, patients then have to go through, typically get stuck on a bunch of phone trees at different CBOs. Eventually they get through to somebody, or someone calls them back and they don't take their insurance, or they don't have an availability until 2 months later. Each one of these steps can be incredibly discouraging for patients. And so understandably, they fall through the cracks. And so for us, we had an existing care management infrastructure that we were able to leverage. And so I would highly recommend that as a point of intervention to include. And the literature supports that. The literature supports liaisons that serve as that glue, as that bridge between the referral and the connection. Partnerships, strongly encourage, it really does take a village. There's enough work to go around. And so identifying where are your systems vulnerable from an access standpoint, and building the right partnerships, but staying engaged and collaborating with those partners so you're solving the problem together. I would say sort of in practice education, whether through repeated rounds, meeting with the practitioners and providers, giving them back information about what you're learning about the referrals from their practice. We have found that to be really powerful in encouraging more referrals. And then providing visual aids, if that, like having a communication strategy. We created postcards that practices can keep in their waiting rooms to encourage patients to let the provider know. We created a worksheet that providers can consult. Like, what's that referral again? How do I make that consult? So they had all of that information handy. And then just one last point, continuously evaluating your work, right? Is our approach working? Does the data tell us the story we want to see? And if it doesn't, kind of problem solving as you go, so you don't go too far afield with a pathway that's not working, because then that will become hard to sustain. I would just say one other thing, as you're planning these pathways, we have learned the value of consulting analytics and making sure you have the right data points from the ground floor. So planning your documentation so that you'll collect the data points that you'll ultimately need to get sound and clear recommendations to come from your work. I think we have found that to be incredibly helpful. So if you have an analytics team, including them in the planning process is probably key. So I'll stop there and turn it over to Andrew or Scott, whoever's going to speak next. Thank you again.
Yeah, definitely happy to take over from here, and appreciate the context and background there. And Anitha, obviously it's been wonderful working together, and excited to talk today about that work and how we've really at Headway increased access to mental health through this referral process. Andrew, if you want to go to the next slide. So to start off with, just want to talk about the challenges that both we see in general and the conversations that we're having with primary care physicians and health systems. I think a lot of this reiterates what Anitha was saying to begin with, right? In terms of that moment of referral being really a moment of potential breakdown in the process. A number of reasons for this. First and foremost, especially within mental health, there's just most therapists, most mental health professionals don't take insurance. And so as a primary care physician or a care manager, care coordinator, really finding that clinician that takes your patient's insurance can be a real struggle. I think we saw it was like 56% of folks in this call said that they have, maybe no specific process in place for making referrals. That number in general is 67% of PCPs really struggling to place patients in with mental health care. Again, in those instances where maybe you do find someone that takes your patient's insurance or has availability, oftentimes just given the fragmented nature of the mental health market, there's really no standard process for making that referral. So one clinician might want you to text them, one clinician might want you to call, one clinician might want to fax. And this just creates a lot of administrative burden for you and your teams that can oftentimes just then result in giving a patient a list of potential resources to use. Finally, in those rare instances where you understand where to send a patient, they have availability, they take your patient's insurance, even in those instances, it's a black box. You send the patient out, and oftentimes you have no understanding for what's happened to that patient. You have no understanding for if that patient has even received care, right? If you go to the next slide. This is all made even more acute by the current moment that we're living through, right? So these are all challenges that have existed for decades, but in a moment where we're seeing a 25% increase in claims year over year in 2020, that's only going to increase in 2021. And frankly, even further down the line, if you look back to the Great Depression, or the Great Recession rather, we didn't really start seeing increases in mental health claims until 2, 3, 4 years after, because the sad fact is people were losing their health insurance and couldn't get access to mental health care in the same way that they could before. So the fact that we're seeing this increase in mental health claims today means that it's only going to be even more exacerbated in the future in terms of really having these challenges around your patients. Go to the next slide. And so Headway has really solved all these problems, right? So across the board, whether it's an access problem, we have the largest in-network provider group in the country. That's 8,500 plus therapists across the 11 markets that we work in. That's 42,000 appointments available in the next 2 weeks. That's a number that oftentimes when I'm talking to a physician, they actually almost don't believe me. And so I have to bring up the stats. They know this is a real number. This is a real number where we can connect patients to care. And that really means that we're not just connecting patients to a warm body. We're not just connecting patients to someone who happens to have availability. We're able to connect patients, and we'll go through this in a moment, but to someone that meets their demographic, specialty, gender, ethnicity requirements so that they are connected to the right care. This is a big reason why at Headway we have a 93 patient NPS and a 90% second appointment retention rate, because patients aren't, again, just getting connected to care, they're getting connected to the right care for them. In terms of the referral process itself, we have a standard referral process that really fits in with a clinical workflow. So whether that means it's a care coordinator who's on their computer and can go to headway.co/refer, Or oftentimes, if you're a clinician and you don't want to go out of your EMR, we work with clinics to add Headway into the EMR. So it's easy as one click to send us a fax referral, and we can take care of the rest. And we'll talk about what that looks like in a moment here. But vastly reducing the administrative burden of making referrals. 80% is the number that we generally see. We'll talk about what that looks like specifically with Sinai in a moment. And then collaborative care. Gone are the days where you refer a patient and you have no idea what's happened to them. In our case, you refer a patient to us, and we will let you know the status of that patient. We'll let you know, are they in treatment? Have they canceled an appointment? And then therefore you should know about that as the quarterback of care. Really getting towards true collaborative care within the conjunction of medical and mental health here. So if we go to the next slide, we'll see a little bit of what this looks like in practice. So as you get a referral, or as a referral gets sent to Headway, your patient will get texted and say, hey, you've been referred to Headway from Mount Sinai. Click on the short link to fill out a short questionnaire that will actually help them to get connected again to the right care. And you can go to the next slide. This questionnaire, again, through the text message, they can either go straight to the questionnaire, or they can just get matched with the provider. If they don't want to go to that questionnaire and they really just want to get matched with the provider right away, that's possible. One thing I'll note here, and this goes back to Anitha, your point of, it isn't just about technology. There needs to be a human touch here as well. And even for folks that don't have care coordination teams, we at Headway have a care management team that will reach out to patients and make sure if they get stuck in this process that they get to care that's needed for them and they understand the context, right? So if a patient maybe gets the text message and is unresponsive, our team will reach out and just say, hey, here to hop on a 15-minute call to match you with a provider. Oftentimes this is a overwhelming time for folks. Folks can be demotivated in this moment. And so want to make sure that we have certainly the technology to support them, but also the human touch to make sure that we can support them as well. Go to the next slide. The 5 questions, really short questionnaire, 5 questions. What do you want to talk to someone about? What gender preferences do you have? Do you have ethnicity preferences? Do you want to be in person or not? Do you want a prescriber, et cetera? So 5 quick questions to then get matched, Andrew, go to the next slide, to a provider that's, again, right for them. So this is a really magical moment if I'm a patient where before I might have been given a link to Psychology Today. I might have been told to go to the United directory. I might have called 15 providers on the United directory. I've gotten 10 voicemails, 3 McDonald's, 1 person who happens to be dead, and 1 person who only has availability in 6 months. And even then, I have no idea what it's going to cost me. From that standard of kind of a patient experience to the patient experience where they've been referred to Headway, I understand how much of this is going to cost me. This is going to cost me $30, which is my copay. They're in network with Aetna, which is great for me. I can get background on this provider, and I know they have availability in the next 2 weeks. I can see, next Tuesday at 10 a.m., I can go and book an appointment with them. And even then, if this provider doesn't work for me, I have 4 other options to look at that fit my demographic needs. So a really, really magical moment for patients to, again, not just get connected to care, but get connected to the right care for them. If we go to the next slide, patients or the physicians that refer us, again, going back to that collaborative care point, will get a closed loop to say, here's the status of your patient. Your patient has started the questionnaire that we sent them, but they actually haven't filled it out all the way. Or your patient has an upcoming appointment. And so this helps to let the PCP, let the quarterback of care really understand the status of their patient, and also lets us know where and when should we be intervening with this patient to maybe get them supported even further beyond just the text message that we're sending them. If you go to the next slide, I think the proof really is kind of in the results here in terms of what we've been able to do with Sinai, but then also with most of our partners as well. So 8 days from referral to appointment. So this isn't just from referral to, oh, I've happened to schedule an appointment. This is 8 days from I've been referred to, I am sitting down with a therapist in care. Relative to, I think the standard there is like 5 to 6 weeks, right? So much, much quicker than the standard of care in terms of getting someone to in-network care that is right for them. In terms of the reduction in admin burden, Anitha talked to her care managers, and they were able to reduce the time that they're spending on their commercial patients by 5 hours a week. 5 hours a week per person, that's a lot of time, but I'm sure if you were a clinician or a care manager or an administrator that's working on this type of work, to get that time back, to focus on whether it's Medicare and Medicaid patients, to focus on other high value opportunities to work on, really, really important to do. And then finally, we're able to track at Headway. We have a quality program. We're tracking GAD, PHQ, and WHO at 30, 60, 90, and 6 months, as well as at intake. Early days of this program, it's a small N today, but we've seen pretty drastic reductions in terms of PHQ and GAD scores, which means that this is working, right? These are not only folks who are getting connected to care that's right for them, but ultimately it's having a clinical impact in terms of their outcomes. As Anitha mentioned, we haven't quite seen, we don't know yet what the total cost of care implications of this are. Obviously, the literature would suggest that, even without knowing what the data is, knowing that we have a reduction in GAD and PHQ will suggest that there will be ultimately total cost of care reductions. And so what I'm excited about in terms of our partnership, where we've proven today, we can increase access, we can connect patients to care, but the next step of that is actually proving that we're able to reduce overall costs, which will be the next step anyway. Yeah, super excited to go, I think, to Q&A from here. But again, thank you so much for the time, and obviously happy to answer any questions, although I'm sure there'll be many questions for Anitha.
Great. Thank you, Anitha, and thank you, Scott. And we've gotten a couple of questions just as a reminder for folks. I know some folks are having to hop off. We will share the recording, including the slides from today's discussion. And actually, for the backdrop of our Q&A, I'm going to just put up your contact information in case folks want to grab that. So definitely feel free to continue using the chat and the Q&A function, folks in the audience. I'll just I'd like to share, as I have the microphone here, I'm just going to share a couple of reflections that I think are pretty interesting. Like one, I think this issue around the actual rate and the process of referrals. And Scott, I think you outlined that really nicely. Like, we've all had some sort of referral in our life, right? Whether it's for behavioral health or otherwise. And that process that you outlined of, okay, well, who takes my insurance? How much is my copay going to be if they take insurance at all? Where they're located? When is the next appointment going to be? Those questions don't even then scratch the surface of even what you talked about as far as like matching by a provider demographic, for example. And then I think the other thing that sometimes we don't take into the equation is when we have a patient who is also dealing with the symptoms of depression that sort of brought them there in the first place, like social determinants of health and factors like transportation that are already and working multiple jobs, things that just add to that burden. The process of seeking that referral is exhausting, and so it's cool to hear about something that makes it a little bit easier. And I wonder if you might share a bit more in particular about this matching process, because I think we just put out a paper where we talked about telehealth and the potential to impact health equity through patient provider matching. We know that when you have a provider who looks like you, who sounds like you, who meets other sort of factors, it may actually result in better care or experience of care. What sort of response do you get to those questionnaires? What have you seen there?
Yeah, definitely. And so, I think I was talking to a psychiatrist at Montefiore yesterday, and he made a great point of, the kind of world that we're in today. If you go back 10, 15 years, people might have not worried about seeing a therapist or mental health professional that was specific. Like, I just want to get to someone to the extent that I need to. Whereas today, I think across the board, we just have higher expectations of customization, of wanting someone in all types of our life that looks and sounds and has the lived experience that we have, right? And so I think going back to some of the stats I shared earlier, I think it's a huge reason why we see the retention rate that we have in terms of second appointment retention rate at 90%. I think it's a huge reason why we're at a 93 patient NPS, because this is oftentimes the first time. I have a friend of mine who, when they saw that I joined Headway, went and sought out therapy for the first time because they were going and needed a therapist that was LGBTQ plus friendly. And for the longest time, they didn't seek that out because it was such a burden and frankly, a barrier for them to find someone. But with Headway, that was incredibly easy for them to find. So I think going back to, if you think our mission at Headway is to make mental health accessible for everyone. And part of that is cost, and part of that is making sure you're in network, but part of that is also just lowering the burden of finding someone that is right for you, that has availability.
Yeah. Lowering the burden in any way, I think is so important. And that's really like, it's such a huge barrier. I have patients I see myself, like even this morning, I was just having a conversation with a patient about who's looking for a mental health provider. And it's just an exhausting process. And so there's a real human element to it. Anitha, there's a question, there's a number of questions that are coming through the Q&A, and there's one that actually probably Anitha and Scott, you might both speak to, but Anitha in particular, I'm wondering, they're asking about barriers that you may have seen in the rollout from providers and patients comfort with the new process. You were pretty specific, Anitha, in terms of talking about the need to be strategic, whether it's selecting which clinic or otherwise. Maybe you could talk a little bit more about what the reception has been like, how you kind of address that.
Yeah, it's such a good question. And I think it's really, important to anticipate that there will be barriers, and some of those barriers are reasonable. You know what I mean? It's sort of, there are logistical barriers a lot of times. Time with the patient is a barrier. How do I bill for this? How do I get credit for having this conversation with this patient is a barrier. And they're not barriers that primary care physicians are happy to talk about, but when they're honest about it, we've really found it helpful to then say, okay, well, this is reasonable. I get it. I get that you want to find a way to make this work, but there are logistical challenges. How can we problem solve that together? So I think coming at it from a point of like empathy for what the experience is like of being in primary care, wanting to support your patients, but there are these challenges with doing it, has helped the conversation kind of proceed to then let's acknowledge that there is a barrier here. Because if you don't, then everybody's happy to say, yeah, we'll test it out, but then it actually doesn't move through. We've found as well, it takes a while to get information kind of absorbed, right, in practices. And that's because the average practice is busy, very busy, and has lots of information that they have to consume and digest and then, implement. So in addition to me talking with our primary care providers and medical leaders within the practices about this behavioral health pathway, someone else is also talking to them about strategies to improve their coding, and someone else is talking to them about strategies to improve their billing and, CMS rule changes. I mean, this last year and a half was full of all kinds of rule changes that they had to understand and accommodate. And so kind of being willing to repeat the same message, right? Go back to them and say, hey, remember I was here a month ago. Here's what we talked about. We're still happy to do this. How's it going? And I've found it as well helpful to go in person to the practices, kind of put some face-to-face time in. And, it really helps bring the information alive. And it's really rewarding for me when folks say, I know I've been sending patients through this referral pipeline. It's been really helpful. Or, I've had situations where people say, I tried to send it through, but I got a bounce back email. And it was something as simple as like their email got stuck behind a firewall. And, no one had known that would happen in the past until they tried it. So we found those sorts of things to be helpful. I will also say, with care coordinators and care managers, there are logistical challenges on their end, right? Large caseloads, lots of patients to have to follow up with. They make a referral and, they have to make sure that it's the right referral. And sometimes the patient changes their mind. I mean, there's all kinds of things that come up on that front. And so being willing to train and retrain folks and remind and re-remind has been helpful. And then the last piece I would say is documentation, right? Like that can turn into a really big barrier, which is why I emphasized getting data analytics involved at the get-go, at the ground floor, and making sure you're anticipating the type of data that you need to collect to gauge. Because otherwise, if you go too far afield, now you've created a barrier where you don't quite know what the program is telling you. So those are the pieces I would emphasize.
Yeah, I think it's a great point. And even it makes me think about on one of your earlier slides at the beginning of the presentation, you mentioned that, like 80% of behavioral health services, especially if we can quantify it even by prescribing, are already being offered in primary care. My experience in training and sort of doing a lot of integrated care work and working with, primary care providers is in many, not in all, but in a lot of cases, there's hesitancy around like, I'm not comfortable, prescribing certain types of medications, or I feel like this is out of my wheelhouse. But it still remains true that a lot, either way it's happening, and it's in our patient population. These are our patients. And I would almost imagine, and I'm sort of asking at the same time, if having like a useful referral source actually helps with feeling more competent or more sort of fluid in addressing behavioral health needs that already exist in the population versus feeling like, oh no, like I'm already, like you said, I have a million other screeners and things that I'm being sort of measured on. I don't feel competent in this and I have no sort of option. Like that's gotta mean something, I would imagine.
Yeah, I mean, and I think we make a mistake of assuming that, primary care providers are not interested in seeking out therapy for their patients and are writing prescriptions because they just want to take a shortcut. I have found in conversations that it's quite the opposite. And to what you said, Andrew, they've tried to get their patient connected with therapy. They get that mild to moderate symptoms are best treated with therapy first. They get the evidence, but can't find a therapist. So I know I'm going to treat the patient the way I know how, which is with medications, right? And bringing in embedded resources, folks that are in the practice that provide short-term therapy, that's easier said than done. I mean, it is doable. There's lots of really good evidence for collaborative care and primary care behavioral health models, including kind of stuff that we're trying to build out at Sinai. But it's not for every practice, particularly smaller ones, right? There can be cost and space constraints and so on. But I do think that, it is a fact that patients talk to their primary care providers about their behavioral health needs. And when primary care providers are able to find a source to refer them to for therapy, they seem to be leveraging it. I think our volume is telling us the same story. And I think it's actually quite encouraging that patients talk to their primary care providers about their behavioral health needs. So I think solutions like this, where we try to maximize that setting as a point of care connection is important.
Anitha, I totally agree with that. And I think one thing you mentioned earlier that I've also heard in many conversations as well is, folks wanting to be able to make this referral but can't, or even going earlier than that and saying wanting to do depression screens for their patients, right? There are many ACOs that I've spoken to that are actually struggling with their depression screens only because clinicians are saying, I don't want to do this because I don't have anywhere to send patients to. Not to say that they don't want to support their patients in that way, but just because they know that if they try to go down that path, that they're going to run against a brick wall. And so again, something that I think we've definitely seen. Another point quickly is the empathy point you made earlier, I think is huge in terms of not assuming that a busy primary care physician or care coordinator can leave their workflow and go and do something completely different, right? Like building something that fits into their workflow that is seamless and easy for them to use, I think is incredibly important and something that I think, frankly, a lot of folks have missed the mark on.
Yeah, and I also, I was sort of thinking about, what helps that referral process. I imagine that, Scott, you mentioned that the component where there's like a report that providers can get as far as how their patients are interacting. Did they make it through the questionnaire? Are they hooked up with services? That's got to be a pretty good reinforcer in the first place. Like I know as someone who's kind of made and received different referrals, like it's not, not only could there be a barrier of like, oh, the consult didn't go through, the email didn't go through, but when I just send people out into the ether and I don't know what happened to them, out of sight, almost assumed nothing great. I don't know. So what kind of response do you get to the feedback or the data that you're then sharing back with the providers?
Oftentimes it's honestly a kind of a desire for more, right? So I think it's this funny thing where I think where we're at is such a step ahead of the standard of care, frankly, today. But I think what we're seeing is there's a desire for even more, not just what's the status of my patient, but what's the care plan? Can you get patient consent to share notes, et cetera? And so that's certainly top of mind for us of, not stopping at, hey, we can do lightweight collaborative care, but what is the true end state of integrating medical and mental health in terms of actually sharing care notes, actually sharing progress notes, actually making sure that you're enabling the primary care physicians to be the quarterback of care.
I like that analogy, the quarterback of care. And Scott, we've got you unmuted. I've got one more for you. And yeah, this is kind of a provocative question, but I think it's an interesting one, and it may speak to sort of how you cultivate a workforce. But one of the participants asked the question, there's sometimes this assumption that therapists, if they're taking insurance primarily, maybe they're sort of not the same caliber or maybe not even that. I would even almost rephrase the question as, a lot of us don't really want to take insurance or deal with the headaches of it. So it's like, I think it's on both sides. You've got this massive workforce. How do you sort of get us engaged, like, and especially those who maybe don't want to be part of the sort of massive, insurance credentialing?
Totally. Yeah. So I think it's a great question, and one that we certainly get a lot. I think first and foremost, you kind of answered the question a little bit in how you asked it, which is, what are the main reasons why someone isn't taking insurance in the first place? It's really just, it's a pain in the butt, right? Like it's a burden to file claims. Then you're doing adjudication. If you get credentialed with one provider or one payer, you then have to get credentialed with all these other payers as well, and that's a process. And what we've been able to do at Headway is basically take care of all of that for the therapist, right? So you can think of us as just a national provider group where we're doing all of the claims management, credentialing, billing, everything for the therapist so that they can focus on patient care. I think then again, the proof is in the results in terms of what we've been able to see, whether it's 90% retention rate, whether it's reductions in GAD and PHQ. Our average therapist is, I think, around 43, and they're 5 to 6 years post licensure. So these aren't, young therapists that are, just getting out into the world and trying to grow a panel. It's really a combination of folks that are just leveraging Headway, one, to deal with the insurance pain points, but then also to say, hey, I'm now able to see more patients in a way that maybe I used to deal with insurance for 10 hours a week. That's 10 hours a week that I can now see more patients, right? So I think two points there. One is obviously the reduction in burden for therapists. And two, I think the proof is in the results in terms of our network being high quality, experienced, and really patient-centric.
Yeah, definitely. I mean, again, like going back to that sort of referral process, there's another process on the provider side, which is also a headache. Anitha, I'm curious your thoughts on this, and also Scott, perhaps. Julian asked an interesting question for patients with chronic conditions, like physical conditions, illnesses, where they mentioned like inflammatory bowel disease, like GI conditions, where there's some sort of like comorbidity. Are there options for that? Like, can you, like, I'm a health psychologist, like, can you say, like, I want someone who specializes in health conditions? Or like, Anitha, is there another way that you've kind of managed that? Again, curious, I don't know the answer.
Yeah, I think, Scott can probably speak more specifically to sort of being able to select folks with specialties. On our end, in the referral making process, given that the referral is coming from primary care, it gives when the social worker calls, and plus with having access to sort of their electronic medical record, it gives them the visibility into what chronic conditions may be going on, what other services that perhaps that same care manager is helping facilitate follow-up appointments for and such. We are not at this point in our referral pathway specifically looking for therapists that have expertise in a particular disease state, medical disease state management. In our model for behavioral health integration that we're building out to launch next year, we are planning to include clinical health psychology emphasis in that, because we're going to be situating the clinician within to provide short-term treatment within a primary care setting. So really wanting to think about that mind body and that sort of chronic medical condition, chronic behavioral health need as part of a whole, and having expertise that can address both sides to the extent that we can. I will just note, particularly with respect to IBD, Mount Sinai's IBD Center has some really good research. In case the person asking the question has a specific need around IBD, they have some really good research focused on psychological interventions for patients with IBD, particularly in the realm of building self-efficacy and resilience, and the impact that can have in reducing IBD symptoms. So that might be something they want to look into or follow up with. But the short answer is our pathway, we're not yet at that point where we're specifically looking for medical expertise among the behavioral health clinicians we're referring to. But Scott.
Yeah, I would say on the Headway front, the best path, and this goes back to earlier where we mentioned the kind of marriage of or combination of technology and a human touch, right? So our care team is able, I would say, to support folks that have specific conditions or needs that are beyond maybe what the referral pathway is able to support. And so in those cases, scheduling a 15-minute call with one of our care managers, who again, these are MSWs, LCSWs, nurses, who know our network, know our therapists very, very well. And so therefore can make that connection in a way that sometimes technology isn't able to on its own, right? So again, that combination, I think, of technology and then human touch is really important here.
Great, and we're down to our last minute actually. So I'm gonna kind of there's actually a number of other questions that we haven't had a chance to get to, and actually a lot of them, Scott, are asking about some of the financial and business elements around Headway, like whether it's supported through different CMS models, exactly like what the business model is, how you sort of interface with insurance. I think these are more than we can get to in 22 seconds. What's the best way to find out in terms of like how do we get hooked up? What are the details?
Yeah, so I would say reach out to me directly. So scott@findheadway.com. Happy to set up additional calls, talk through business model, talk through specifics in states or regions, right? I think one question here was just quickly on, have we had struggles in certain regions or areas? And I would say, yes, but the beauty of the Headway model is that we're both virtual and in person, right? So in those areas where there is maybe lack of access just due to being rural in nature, what have you, we're able to then supplement in-person meetings with virtual meetings as well. But yeah, scott@findheadway.com and happy to follow up with additional questions.
Awesome. And Anitha, I think it's very exciting. I'm curious to see sort of what this next phase of integration looks like. Is there a way that we can follow along with what's going on at Sinai? Can folks reach out to you? What's the...
Absolutely, folks can reach out to me. My email is on the screen. Yeah, and I'm happy to keep people posted. I mean, I keep you posted in the community as well as we kind of move through the phases of what I had shared earlier. But yeah, exciting.
Great. All right. Well, thanks to you both, and thanks for everyone for joining us. And you can kind of stay tuned with the work we're doing at pcdc.org. Make sure you're on our mailing list for more discussions like these. We'd love to have you both back. And thanks again for the opportunity to have this great conversation. It's so timely. Again, folks will get the recording of today's session probably later this week as it becomes available. Thanks very much.
Thanks again. Bye.
Bye-bye.
Thank you.